Welcome to Pediatric Case Review. I'm Dr. Abdelaziz Yousef, and today we'll be discussing Eisenmenger Syndrome in pediatric patients. This lecture provides an overview of this serious cardiovascular complication for practicing pediatricians. We'll cover pathophysiology, clinical presentation, diagnosis, management options, and prognosis. Let's begin our exploration of this important topic. Let's start with our first case. A 15-year-old with Down syndrome presents with progressive cyanosis and exercise intolerance. He has a history of unrepaired ventricular septal defect. What is the primary pathophysiological process in Eisenmenger syndrome? Is it A. Primary pulmonary hypertension, B. Left to right shunt becoming right to left due to pulmonary vascular resistance, C. Right ventricular outflow tract obstruction, or D. Left ventricular failure? The correct answer is B. Eisenmenger syndrome represents the end stage of unrepaired congenital heart defects with initial left to right shunting. Over time, excessive pulmonary blood flow leads to pulmonary vascular obstructive disease and increased pulmonary vascular resistance. When pulmonary pressure exceeds systemic pressure, the shunt direction reverses to right to left, resulting in cyanosis and the clinical manifestations we observe in Eisenmenger syndrome. For our second question, which of the following cardiac defects is least likely to lead to Eisenmenger syndrome? Is it A. Large ventricular septal defect, B. Atrial septal defect, C. Patent ductus arteriosus, or D. Small muscular ventricular septal defect? The correct answer is D. Small muscular ventricular septal defects rarely cause enough left to right shunting to develop Eisenmenger physiology. Eisenmenger syndrome typically develops in patients with large, unrepaired defects that allow substantial left to right shunting. The most common lesions include large ventricular septal defects, atrial septal defects, and patent ductus arteriosus. The size and location of the defect directly impact the likelihood of progression to Eisenmenger syndrome. Let's consider our third case. A 12-year-old with known atrial septal defect presents with progressive exercise intolerance, headaches, and dizziness. Which physical finding would be most consistent with Eisenmenger syndrome? Is it A. Loud holosystolic murmur, B. Digital clubbing with central cyanosis, C. Continuous machinery murmur, or D. Hyperactive precordium with gallop rhythm? The correct answer is B. Digital clubbing with central cyanosis is highly characteristic of Eisenmenger syndrome. These findings reflect chronic hypoxemia from right to left shunting. Interestingly, as pulmonary vascular resistance increases, the cardiac murmurs typically become softer or may disappear entirely. A loud holosystolic murmur actually suggests active left to right shunting, which occurs before Eisenmenger physiology develops. A continuous machinery murmur would be characteristic of a patent ductus arteriosus with left to right flow. For our fourth case, a 10-year-old presents with cyanosis, clubbing, and fatigue. Physical examination reveals upslanting palpebral fissures, flat nasal bridge, and single palmar crease. Which syndrome is commonly associated with Eisenmenger physiology? Is it A. Down syndrome, B. Turner syndrome, C. Marfan syndrome, or D. Williams syndrome? The correct answer is A. Down syndrome has a high incidence of congenital heart defects, occurring in 40 to 60% of affected individuals. The most common cardiac lesions in Down syndrome include atrioventricular canal defects, ventricular septal defects, and atrial septal defects. These defects, if large and left unrepaired, frequently progress to Eisenmenger syndrome. The physical features described in the case, upslanting palpebral fissures, flat nasal bridge, and single palmar crease, are classic features of Down syndrome. For our fifth case, a 16-year-old with unrepaired ventricular septal defect presents with cyanosis and dyspnea. Which cardiovascular examination finding is most consistent with Eisenmenger syndrome? Is it A. Loud pulmonary component of second heart sound with right ventricular heave, B. Loud holosystolic murmur at left sternal border, C. Widely split second heart sound that narrows with inspiration, or D. Prominent third heart sound gallop with displaced apical impulse? The correct answer is A. A loud pulmonary component of the second heart sound with a right ventricular heave is characteristic of Eisenmenger syndrome. These findings reflect pulmonary hypertension and right ventricular hypertrophy. Interestingly, as Eisenmenger physiology develops, the ventricular septal defect murmur often diminishes or disappears as pressures equalize across the defect and shunt flow decreases or reverses. A widely split second heart sound that narrows with inspiration would be more consistent with an atrial septal defect before developing Eisenmenger physiology. For our sixth case, a 14-year-old with known patent ductus arteriosus presents with decreased exercise tolerance. an electrocardiogram is obtained. Which electrocardiographic finding is most suggestive of Eisenmenger physiology? Is it A. Left ventricular hypertrophy, B. Right ventricular hypertrophy with right axis deviation, C. First-degree AV block, or D. Left bundle branch block? The correct answer is B. Right ventricular hypertrophy with right axis deviation is the most characteristic electrocardiographic finding in Eisenmenger syndrome. This reflects right ventricular adaptation to pulmonary hypertension. Other common findings include peaked P waves, indicating right atrial enlargement. The electrocardiogram pattern often mirrors the physiologic progression of the disease, initially showing left ventricular hypertrophy due to volume overload, then evolving to right ventricular hypertrophy as pulmonary hypertension develops. Conduction abnormalities like AV block or bundle branch block may occur, but are less specific. For our seventh case, a 12-year-old with unrepaired atrial septal defect has progressive dyspnea. A chest X-ray is performed. Which chest X-ray finding is most characteristic of Eisenmenger syndrome? Is it A. Pulmonary plethora with cardiomegaly, B. Pulmonary oligemia with right heart enlargement, C. Normal heart size with increased bronchovascular markings, or D. Left atrial enlargement with pulmonary edema? The correct answer is B. Pulmonary oligemia with right heart enlargement is the classic radiographic finding in Eisenmenger syndrome. Pulmonary oligemia, sometimes described as pruning of peripheral vessels, reflects reduced pulmonary blood flow due to increased pulmonary vascular resistance. Right atrial and ventricular enlargement occur due to pressure overload. The main pulmonary artery is typically dilated. This pattern contrasts with the pre-Eisenmenger radiographic findings of pulmonary plethora with cardiomegaly, which reflect the initial left to right shunting phase. For our eighth case, a 15-year-old with known ventricular septal defect undergoes echocardiography to evaluate worsening exercise tolerance. Which echocardiographic finding confirms Eisenmenger physiology? Is it A. Left ventricular volume overload, B. Bidirectional shunting with estimated right ventricular pressure greater than systemic pressure, C. Tricuspid regurgitation with normal right ventricular pressure, or D. Patent foramen ovale with left to right flow? The correct answer is B. Bidirectional shunting with right ventricular pressure exceeding systemic pressure is the diagnostic hallmark of Eisenmenger syndrome. Color Doppler typically shows bidirectional or predominantly right to left shunting across the defect. Additional echocardiographic findings include right ventricular hypertrophy, right atrial enlargement, and often tricuspid and pulmonary regurgitation. The severity of tricuspid regurgitation allows estimation of right ventricular pressure, confirming pulmonary hypertension. Echocardiography also identifies the underlying congenital defect, whether ventricular septal defect, atrial septal defect, or patent ductus arteriosus. For our ninth case, a 10-year-old with Eisenmenger syndrome from an unrepaired ventricular septal defect develops worsening cyanosis. Which of the following is contraindicated in this patient? Is it A. Supplemental oxygen therapy, B. Pulmonary vasodilator therapy, C. Surgical correction of the ventricular septal defect, or D. Iron supplementation for iron deficiency? The correct answer is C. Surgical correction of the ventricular septal defect is contraindicated in established Eisenmenger syndrome. Once irreversible pulmonary vascular disease develops, closing the defect would remove the pop-off valve for the right ventricle, resulting in right heart failure and potentially death. Appropriate management includes pulmonary vasodilator therapy, supplemental oxygen during hypoxemic episodes, and iron supplementation for iron deficiency, which can worsen symptoms. Heart-lung transplantation remains the only definitive treatment option, though pulmonary vasodilators have significantly improved quality of life and survival. For our 10th case, a 16-year-old with Eisenmenger syndrome due to atrial septal defect has progressive exercise intolerance despite conventional therapy. Which medication class has shown benefit in Eisenmenger syndrome patients? Is it A. Calcium channel blockers, B. Endothelin receptor antagonists, C. Beta blockers, or D. Angiotensin-converting enzyme inhibitors? The correct answer is B. Endothelin receptor antagonists, particularly bosentan, have shown benefit in patients with Eisenmenger syndrome. Clinical trials have demonstrated improved exercise capacity, hemodynamics, and functional class. Other beneficial medication classes include phosphodiesterase 5 inhibitors such as sildenafil and prostacyclin analogs for severe cases. These pulmonary vasodilators target the pathophysiology of pulmonary arterial hypertension. Calcium channel blockers, while used in some forms of pulmonary hypertension, are generally ineffective and potentially harmful in Eisenmenger syndrome. Beta blockers and ACE inhibitors have not shown benefit and may worsen hemodynamics. For our 11th case, a 14-year-old with Eisenmenger syndrome presents with sudden onset headache and right-sided weakness. Which complication of Eisenmenger syndrome is most likely in this patient? Is it A. Cerebral abscess, B. Cerebrovascular accident, C. Migraine with aura, or D. Todd's paralysis? The correct answer is B. Cerebrovascular accident is a significant complication of Eisenmenger syndrome. The right-to-left shunting allows paradoxical emboli to bypass the lungs and enter the systemic circulation, potentially causing stroke. Additionally, the secondary polycythemia associated with chronic cyanosis increases blood viscosity and thrombosis risk. Other common complications include hemoptysis from pulmonary artery rupture, brain abscess due to bypassing of the pulmonary bacterial filter, syncope, and arrhythmias. Any neurological symptoms in a patient with Eisenmenger syndrome warrant urgent evaluation and management. For our 12th case, a 17-year-old female with Eisenmenger syndrome is considering her reproductive options. What is the most appropriate counseling regarding pregnancy? Is it A. Pregnancy carries minimal risk with close monitoring, B. Pregnancy is associated with 30 to 50% maternal mortality, C. Cesarean delivery eliminates pregnancy-related risks, or D. Pregnancy is safe with pulmonary vasodilator therapy? The correct answer is B. Pregnancy in Eisenmenger syndrome is associated with extremely high maternal mortality, ranging from 30 to 50%. The physiological changes of pregnancy, including increased blood volume and cardiac output, are poorly tolerated in patients with fixed high pulmonary vascular resistance. Significant fetal risks exist as well, including growth restriction, prematurity, and loss. Effective contraception is essential, with progesterone-only options generally preferred. Neither cesarean delivery nor pulmonary vasodilator therapy eliminates these risks. Pregnancy is considered absolutely contraindicated in Eisenmenger syndrome, and appropriate counseling is critically important. For our 13th case, a 10-year-old is newly diagnosed with Eisenmenger syndrome due to an unrepaired atrial septal defect. What is the approximate median survival for patients with Eisenmenger syndrome? Is it A. 10 to 15 years, B. 20 to 30 years, C. 30 to 40 years, or D. 50 to 60 years? The correct answer is C. The median survival for patients with Eisenmenger syndrome is approximately 30 to 40 years without advanced therapies. With modern pulmonary vasodilator therapy, survival has improved. Interestingly, patients with Eisenmenger syndrome have better survival compared to other forms of pulmonary arterial hypertension with similar pulmonary pressures. This is likely due to the preservation of right ventricular function from birth and the right-to-left shunt acting as a relief valve. Poor prognostic factors include syncope, arrhythmias, right heart failure, and pregnancy. Early diagnosis and management are essential to optimize outcomes. For our 14th case, a 12-year-old with Eisenmenger syndrome needs dental extraction. Which of the following is most important in the perioperative management? Is it A. Avoiding dehydration and maintaining systemic vascular resistance, B. Administering prophylactic antibiotics, C. Using general anesthesia instead of local anesthesia, or D. Preoperative phlebotomy to reduce viscosity? The correct answer is A. Avoiding dehydration and maintaining systemic vascular resistance are critical in the perioperative management of Eisenmenger patients. Decreased systemic vascular resistance or hypovolemia can worsen right-to-left shunting, leading to increased cyanosis and potential cardiovascular collapse. While endocarditis prophylaxis is important, maintaining hemodynamic stability is the primary concern. General anesthesia carries significant risks and should be avoided when possible. Phlebotomy is only indicated for symptomatic hyperviscosity with very high hematocrit values, typically above 65%, as routine phlebotomy may lead to iron deficiency and paradoxically worsen symptoms. For our 15th case, a 16-year-old with Eisenmenger syndrome has worsening functional status despite maximal medical therapy. Which treatment option offers the best chance for long-term survival? Is it A. Pulmonary vasodilator combination therapy, B. Surgical correction of the cardiac defect with pulmonary endarterectomy, C. Heart-lung transplantation, or D. Atrial septostomy? The correct answer is C. Heart-lung transplantation remains the only potentially curative option for Eisenmenger syndrome. This may involve combined heart-lung transplantation or bilateral lung transplantation with repair of the cardiac defect, depending on the specific anatomy. While offering the best chance for long-term survival in end-stage disease, Transplantation carries significant procedural risks and is limited by donor availability. 5-year survival following transplantation is approximately 50%. Surgical correction of the defect alone is contraindicated due to fixed pulmonary vascular resistance. Pulmonary vasodilator therapy can improve quality of life, but isn't curative. Thank you for joining us for this comprehensive review of Eisenmenger Syndrome in pediatrics. We've covered the pathophysiology, clinical presentation, diagnostic approach, and management options for this complex condition. Remember that Eisenmenger syndrome represents the end stage of unrepaired congenital heart defects with shunts, characterized by pulmonary vascular disease and reverse shunt flow. Management focuses on pulmonary vasodilator therapy, prevention of complications, and appropriate consideration of transplantation. These patients require multidisciplinary care in specialized centers. Please follow the Pediatric Case Review channel for more informative presentations and leave any questions in the comments section below. Thank you for watching.